2, 1, start.
Very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Man Singh Medical College, Jaipur. Today, we have a class on posterior valves, and this will be presented by our resident, Dr. Yash Sharma, and would be moderated by our faculty, Dr. Ajajraj. So I request Yash to kindly share his presentation. Good morning, everybody. My respected teachers, I am going to present a webinar on urethral anomalies and post-war. So, before jumping on topic, I am giving a briefing about how urethral plate and bladder is formed. Cloaca divided into primitive urogenital and primitive rectum. This primitive urogenital sinus forms divided into two parts: vesico-urethral canal and definitive urogenital sinus. Upper part of the vesico-urethral canal forms the bladder, and lower part of this vesico-urethral canal forms the bladder neck, prostatic urethra up to verumontanum. And the caudal part of definitive urogenital sinus forms the membranous urethra, and phallic part of definitive urogenital sinus forms the penile urethra. In developmental of urethra, there is a phallic part of definitive urogenital sinus forms the vestibule, where the urethral opening is present. So there are certain anomalies of urethra, like post-urethral valve due to presence of cloacal membrane, hypos. In literature, we see first Morgagni in 1769 describes there is some congenital obstruction at posterior urethra, which having valve-like leaflets, which is later clarified by Langenbeck in 18th century, and more than a century after, this huge Hampton Young, which is known as American pediatric urology father, defined and named it posterior urethral wall. And after 1 year in 1920, Randall first did an endoscopic ablation of posterior urethral wall. This walls is a misnomer; it implies no function. So it is a most common structural anomaly which causing outflow obstruction. Which it is also a most common obstructive uropathy leads renal failure. The incidence is 1.4 to 2.1 in 10,000 live births, and 10 to 12 to 10% prenatally diagnosed with fetal hydronephrosis in oligohydramnios patients. It's higher incidence in black patients. There are certain theories like hypertrophy of mucosal fold, cloacal remnant after division of urogenital membrane, abnormal development of Wolffian or Mullerian duct, persistent oblique urogenital membrane, which uh, causes a posterior urethral wall. There are types, three types. Huge Hankton Young. Type 1 is most common in 95 cases present. It usually arrives distal from the viromontanum and inserted in midline. Type 2 is very infrequent, which present proximally from the viromentorum and extended superior laterally up to the bladder neck. And type 3 is an annular ring, which is because of the persistence of urogenital membrane. It is a membrane sheet which directed upwards and forwards, and anteriorly there is a complete fusion, while cleft was between the folds posteriorly. Type is very uncommon. It is in 5%. There are evidence that type 3 wall also worse prognosis. Then pathophysiology, because of the bladder outlet obstruction, it causes increase in intraluminal and which causes universal injury in the upper urinary tract. So, in bladder outlet obstruction in early life leads to bladder hypertrophy, which causes high voiding pressure to maintain complete voiding of bladder. Up to this stage, it is compensated phase, and later on, it gradually remodeling of bladder wall because of the deposition of extracellular matrix, collagen type 3, and this will lead to further increase in the voiding pressure and incomplete emptying of bladder as bladder begins to fail to void. If patient develops increase in urine output, then there will be chances of normal growth and development. But if there is a high posted post voiding residual, and overflow incontinence will occur, and urinary reflex will damage the, and further renal damage will occur. There are certain effects on various organs like lung due to hypoplasia, and it is the most common formation of posterior urethral wall. In kidneys, glomerular injuries will happen like obstructive uropathy up to obstructive uropathy. And in tubular injuries, there is inability to limit sodium and water loss. In bladder, there will be a poor sensation, hypercontractibility, and low flanks, which leads to incontinence, poor emptying. And in ureter, there are inability to adapt and transport urine, which will cause renal dysphagia. In lower urinary tract dysfunction, root causes a dysfunctional bladder. Bladder distension with bladder wall remodel leads to upper urinary tract dilation, which leads to renal dysphagia. There are certain features of bladder outlet like posterior urethral dilatation more than 5 times, 5 raised to 1 as compared to anterior urethral diameter, bladder neck hypertrophy, and dilated ejaculatory ducts. In upper urinary tract, urethral dilatation leads to UR in 70% of the cases, and chronic urethral dilatation will lead to wall thickening of ureter, loss of adaptation and peristalsis, increased urinary stasis and infection, and increased intrarenal pressure leads to renal dysplasia. And renal dysfunction in utero obstruction due to renal development is irreversible. VURD syndrome is a triad of posterolateral wall, vesico-urethral reflex, and ipsilateral renal dysplasia. Contralateral kidney is also risk for renal dysfunction and end-stage disease. There is a pop-up mechanism which will previously said that due to pop-off mechanism of bladder and ureter, the opposite kidney will be safe, but it is not like that. Pop-off mechanism is due to because of bladder diverticula, urinary ascites, and rarely by patent urachus. Clinical presentation in newborns will be a palpable abdominal mass like a small walnut in suprapubic area. 40% in cases there will be a ascites and respiratory distress from pulmonary hyperplasia. In early infancy, there will be a growth retardation, electrolyte imbalance, dribbling on urosepsis. And in toddlers, there is most common presenting feature is a febrile UTI and daytime incontinence. Definitely, it will be diagnosed by anomaly scan, which we do at 24 weeks. It is 10% of the all antenatal urinary anomalies, and pathognomic feature is ureteronephrosis, and dilated posterior ureter like keyhole sign and increased renal leukogenicity. And immediately after birth, we can do a sonography of KUB, which will describe cortical leukogenicity, corticomedullary differentiation, and degree of hydronephrosis, dilatation, for distension, thickness, and high bladder neck with retrostal hypertrophy, and posterior dilatation. And in some cases, urinoma, which is also known as neonatal ascites, which is present in 3 to 10% cases because of fornicel rupture, transperitoneal transduction, and bladder rupture. Fetal MRI, it does not provide any cause of obstruction. To distinguish the degree of obstruction based on urethral dilatation, and it gives benefit to see a lung hyperplasia and cystic changes in the renal parenchyma. Coming on management at birth, management at a bladder spasm, and sample of urine for culture sensitivity is collected and sent for routine work. IV lines to be secured by and giving IV fluids and IV antibiotics. Our aim is further dehydration and acidosis and electrolyte imbalance, and vigorous monitoring to be done. Voiding cystourethrogram, it is a definitive investigation for hemodialysis patients. Antibiotic dialysis is needed. The method for child to void is a suprapubic massage, pinching of glands, sprinkling cold water of glands. The condition of bladder, which we can see, is trabulation and diverticula. In 50% cases, we can see high-grade reflux, elevated bladder neck and hypertrophy, dilatation and increase in length of the posterior urethra, and abrupt funneling and configuration of obstructive and certain complications of rigorous widening cystourethrogram is a rupture bladder due to overdistension. We can estimate the bladder capacity by Koch formula, and we have to give exact that amount by IFT and remove the IFT to self-micturate the patient in voiding cystourethrogram. Radionucleotide scans offers quantification of differential renal function, and they are it to be done by MAC3 or DMSA scan, And placement of the urinary catheter is essential in patient with varicose. The advantage of early valve ablation is option-free drainage, and which improves the compliance of bladder stability in patients' infancy, with the possibility of less bladder and possibility of reversal of bladder and kidney uropathy. So, endoscopic fulguration, we use four types of instruments like buggy, which is possible through neonatal scope, easily available. But the problem is it usually cannot engage with the posterior urethral wall. The right angle electrode is usually engages well, clean cut, but because of the energy source, it will cause a lateral injury and lead to stricture in later. Laser PUV fulguration, laser probe is passable by a neonatal scope, and there is a less cut in the surgical area. And due to vibration, it is not cut precisely, and it is costly. Bobby electrodes, we usually cut at the 5 o'clock position and 7 o'clock position. And if there is anteriorly, if there is a fused, both urethral walls are fused, then 12 o'clock incision is also needed. It is a short video of posterior urethral wall fulguration, in which we can see severe trabeculation in the bladder. Then there is dilated posterior urethra with viromontanum. By withdrawing the scope, we can see there is slit-like wall present just beyond the viromontanum. Here we are engaging the electrode probe to the posterior urethral wall position. And then the 7 o'clock position. This technique is obsolete nowadays, in which we introduce a 4 French Fogarty or catheter, and balloon is inflated with 0.75 ml, and sharp withdrawal will lead to rupture of membrane without injury to urine, but it is obsolete nowadays. So how do we follow up? In post-fulguration, in 2 to 3 days, we do a sonography, some creatinine and electrolytes, and monthly analysis, urine culture, patient height, weight, and 3 monthly sonography to look for dilatation of PCA system and ureter and post residual volume. And repeat mixture-rating cystourethrogram at 3 months of post-fulguration for any residual wall. Cystoscopy, if there is any significant obstructive changes in mixture-rating cystourethrogram, and DMSA at 3 months for cortical function. Open technique of diversion is vesicostomy. It is usually indicated in very low grade infants, not accommodating endoscope, and in very severe urosepsis. And there is we have done posterior wall fulguration, but it failed and causing urinary tract deterioration. So in this technique, we give an incision of 3 to 4 centimeters transversely just above the pubic symphysis. We open the bladder transversely and we fix this bladder wall with rectus sheath and the bladder mucosa to the skin. Then there are certain types of supravesical diversion. It is to direct low pressure renal drainage to optimize renal function. The indication is complete decompression of urinary tract in patients with worsening renal function even after doing vesicostomy, increasing upper tract dilatation and clinical picture of sepsis. The possible cause is compression of intramural ureter by a thickened bladder wall. The disadvantage is reversion is very cumbersome. So this is colostomy, and all these types of supravesical diversion is the anstomal ureterostomy. Is then ureterostomy. The problem with loop ureterostomy is ischemia of ureter. Then cutaneous pilostomy, it is the best type, but we need a dilated pelvis in this case. And ring ureterostomy and sober Y ureterostomy. In this ring ureterostomy and sober Y ureterostomy, bladder compliance is maintained because some part of urine is going to the bladder. So, in management of vesicoureteral reflux, it's mainly focused to maintain a low pressure system and high complication rate of UR surgery. Persistent of UR even after doing vesicostomy because of the residual wall, altered bladder dynamics, and paraureteral diverticular, which is known as Hutch diverticular. Bladder neck incision is no evidence of benefit, and circumcision is recommended if patient is having vesicular reflux even after posterior wall fulguration, and 90% of these cases relieved with circumcision itself. So before giving any consideration for ureteral replant in VUR patients in a febrile urinary tract infections, despite conservative measurements, we should go for circumcision. Bladder dysfunction in posterior are three distinct evolutionary pattern. In infancy or early childhood, there is a retrocessor hyperreflexia. In late, decreasing intravesical pressure and improving compliance. And in adolescence, increased capacity of bladder and hypocontractility and bladder function UV long-term follow-up is mandated. With clinical examination, assessment of voiding with help of observation, Uroflow studies, posterior post voiding residual and urodynamic study, and upper tract assessment with sonography. Bladder management, voiding training to be done with CC. Inability to catheterize, then we have to go for appendicovesicostomy, which is known as Mitrofanoff procedure. Anticholinergics to be started. Alpha blockage to relax bladder neck, and refractory to therapy of small contact bladder augmentation. Decreased compliance of bladder, which causes upward pressure increase in pelvis, which leads tubular damage, and this will cause a polyuria, and it will drain into the bladder and still increases the posterior wall, post-void residue. So there are indicators for renal functions. The favorable indicator as serum creatinine should be less than 1 milligram per deciliter at 1 year. Absence of vesicular reflex, presence of corticomedullary function, renal parenchyma area, age at the diagnosis, and absence of bladder dysfunction. Renal transplant in patient treated with posterior wall is bladder dynamics is essential prior to go for renal. More than 300 ml, low end phase filling pressure less than 30 centimeter of good flow rate, at least Q max of 18 and 18 to 25, absence of inherited detrusor contraction and incontinence. The augmentation is necessary if unsafe storage pressure in bladder, and pre-transplant augmentation is safe to prevent undertaking of immunocompromised child, which leads to wound and one too young to take responsibility of catheterization and AIC. And recent experience argues with the transplantation into even a vesicostomy is a safe alternative until the child grows an appropriate age for CIC. And antenatal interventions are required and indicated in oligohydramnios, dilated bladder with severe hydroureter nephrosis. Beta 2 microglobulin less than 6 milligram per deciliter, which shows a patency of tubules. There are two types of procedures we can do, like amniotic shunt, which is known as reduction, which improves the survival in worst cases by improving the pulmonary function and renal function, but high complication rate like migration of stent, obstruction, and displacement. And fetal cystoscopy with or without posterior urethral wall fulguration, in 8 to 9%, there will be a chance of fistula formation and recurrence of lower urinary tract obstruction.
Thank you, Dr. Yash. Before we go ahead with the MCQs and other queries which may be there from our residents or faculty, I would request Dr. Bhatt, if you can unmute yourself, would you like to give some of your comments on post-urethral valve management? Dr. Bhatt, please.
Hello.
We have Dr. Anil Jain also with us. If Dr. Anil Jain also wants to make some comments, he is most welcome.
Hello.
Dr. Bhatt, yes, please go ahead.
Yeah. I think it's a very good review of the post-urethral valve and its management. There are a few of the clinical points which I would like to stress upon is that one thing that vasectomy, indications of vasectomy has now reduced only because of availability of the instruments. Earlier, it was that in most of the cases of post-urethral valve vasectomy was done in want of the instruments. Now, if the cystoscope, pediatric cystoscope is not available, then the ureteroscope is available almost in all centers, and that can be done. And another one is that fulguration. While we are going, I would like to say that it's better to go under fulguration than an over fulguration, either with the laser heat management or the thermal heat management. And if the stricture becomes, then it becomes a very bad problem. And recently, I have come across two patients to whom many times patients present in later age, at the age of 6 years, 8 years, or 12 years. In such cases, I have come across two cases where people have done VIU, misdiagnosing as a case of stricture. So this should be taken care by the youngsters when they are taking that. You diagnose, and MCU is the diagnosis, and in these 5 radiological signs which he has already described are important one. And then ultimately the follow-up is very important, and at appropriate time. Most of these patients will land in CRF in the teenage group, and they need a renal transplant. So better renal replacement at a proper time will save their life and prolong their life. Thank you very much.
Thank you. Thank you, Dr. Bhatt. The points are well taken. First of all, vesicostomy, yes, the indications are reducing day by day with the improvement in the technology and the finer pediatric scopes and ureteroscope also, by which we can do even in neonates, we can do fulguration. If necessary, we can do with laser also, if we cannot pass a pediatric resector scope. I think very important. And the second was about you said about, huh? The second point was about over fulguration. Yes, it is always better to under rather than over than the uh, morbidity with a stricture post fulguration would be definitely much more in these children. So both the points are well taken. So Dr. Anil Jain is with us. Dr. Anil, would you like to make some comments? Yes. Unmute yourself, please. You are muted, please. You are muted. Can you unmute yourself? Mr. Nimesh, can we unmute him?
Sir, I have asked him for unmute, sir.
Okay. Right. Dr. Anil, you are still not, you are muted still. So in the meantime, I would request, yes, go ahead. Now you are muted, yes.
Yeah. All the points have been very well
Yes, go ahead.
summarized, Bhatt and you. One thing is, in my experience, what I have found that this is a very peculiar disease where the prognosis is very variable. And the POV has so much of a spectrum from an isolated POV with no effect on urinary tract to the worst dysplasia of kidney and the dysplasia of bladder, and all contributing to the ultimate deterioration in renal function and the prognosis. So while taking up these patients, it is very much important to describe to the patients all these points in advance and impress upon them that the regular follow-up every 3 months is very important for first few years. So this is what I would like to say. Rest everything you and Dr. Bhatt have already said. Thank you very much.
Thank you, Dr. Anil, for first of all joining us in our today's class. I apologize for the instability of the net today we had. So anyway, we could manage it. So you raised a very important point that it is not only just the management of the posturethral valve, but also the consequences of posturethral valve, which are very important, namely the vesico-ureteric reflux, the chronic medicorenal disease, which can end up as end-stage renal disease, and bladder dysfunction, which need to be monitored regularly in these patients, and the patient and its attendants all need to be counseled before the management has to be done. Yes, thank you very much. So I think what we will do is I will briefly summarize the whole thing, and then we'll take up a few MCQ questions with our residents. So let's go ahead and so briefly, the summary of the posturethral valve is that this is the commonest obstruction in newborn males, and this is also the commonest obstructive uropathy causing chronic kidney disease in infants. So it's very important to manage these cases of posturethral valve. The incidence is around 1,000 pregnancies, and the presentation could be either prenatal or postnatal, right? Prenatal presentation, usually by antenatal sonography, you will see dilated bladder and hydroureter nephrosis and the typical keyhole sign, which is there. And we all know that they need very selected cases of antenatal posturethral valve could be managed by vesicoamniotic shunt or fetal cystoscopy fulguration. So, but the cases are very selected because one of the foremost is the expertise is not there everywhere. Secondly, the risk of chronic kidney disease, even after fetal intervention, remains quite high. It is still debatable that whether it reduces the CKD. And thirdly, the morbidity associated itself with the shunting and the fetal intervention. And for these reasons, very, very selected cases are to be intervened. The postnatal management, usually the patients will present with lower urinary tract symptoms, difficulty in voiding, and sometimes they may present with abdominal distension, respiratory distress, and some older boys can present with recurrent urinary tract infection, enuresis, and all these things. Of these patients who have severe bilateral hydrourethral nephrosis can present with urosepsis and respiratory distress also. So these things should be taken into consideration. The differential diagnosis could be the causes for urethral obstruction, like megalourethra, urethral stricture, meatal stenosis. All these should be taken into consideration once you diagnose a case of posturethral valve. Uh, uh, the management, again, as I said, the prenatal management, as we have said already, the postnatal management, the first of all, we need to stabilize the patient. If the patient has some problem, is unstable, like there may be electrolyte abnormalities in the form of hyperkalemia or decreased bicarbonate, etc. The patient may be in respiratory distress or even in urosepsis. So all these patients need to be managed. The medical management has to be done for urosepsis, respiratory distress, and electrolyte abnormalities. And then we need to drain the patient. So usually, immediately, if required, we can put a 5 to 8 French feeding tube to drain the bladder, and or we can go ahead immediately with a neonatal cystoscopy and cystoscopic fulguration of the posturethral valve. Many of these patients can develop a lot of other things post management of posturethral valve. As I said, they would be managed for vesico-ureteric reflux, they need to be managed for bladder dysfunction, and they need to be managed for chronic kidney disease. So regular follow-up and monitoring of these patients are very important. And we have seen that around 15 to 20% of these patients may end up in end-stage renal disease, which requires a renal replacement therapy. And bladder dysfunction, again, is very common in these patients, and we need to manage these patients with either anticholinergics or even clean intermittent catheterization or other surgical procedures if required. So that was in brief the summary. And now we will go ahead with yes. The first question is about all the following findings of antenatal imaging should raise a suspicion of posterior valve, except a thickened bladder wall, bilateral pelvic cases and urethritis, oligohydramnios, ambiguous genitalia, and dilated posterior urethra. And right. So all the findings are characteristic findings of the posterior valve, except the ambiguity. All right. The second question: all of the following are true regarding antenatal diagnosis and management of posterior valve, except thickened dilated bladder with bilateral. Sorry for the net problem. So all the following are true regarding antenatal diagnosis and management of POV, except thickened dilated bladder with bilateral dilatation, significant renal cortical dysplasia. Vesicoamniotic shunting has been shown to improve renal failure rates. Early reports suggest that fetal cystoscopy and valve ablation might offer better outcomes than vesicoamniotic shunting. Antenatal intervention should only be offered in select cases as outcomes are not universally predictable. C, right. So vesicoamniotic shunting has been shown to improve renal failure rates. As I said, there is still a debate. So C is the right answer. Third question is, yeah. So we can go ahead with the third question, please. So newborn infant with a history of hypernephrosis and oligohydramnios. All the following are characteristics findings of posterior valve: hypertrophy and apparent elevation of the bladder neck, multiple bladder diverticula, bladder perforation with small amount of urinary extravasation causing ascites, rupture of an upper pole calyceal fornix causing distortion, all of the above. Bladder perforation is usually not there. And usually this ascites results from a rupture of the calyces, and perforation should not be there in a case of bladder. I think yes, fetal and neonatal lower unit tract obstruction due to POV may be enough pressure in the tract cause a rupture of the calyceal fornix, and the urine may be trapped within the renal capsule or cause ascites in rare cases. However, bladder perforation is not a characteristic of posterior valve, since the process actually leads to significant bladder wall hypertrophy. So the rupture is almost not possible. The most cause of early neonatal mortality in a baby affected by posterior valve is urinary sepsis, end-stage renal disease, pulmonary hypoplasia, urinary ascites, and necrotizing enterocolitis. So C, yes. So the cause for early mortality, not morbidity, it's mortality. Mortality is pulmonary hypoplasia. Yes. So the focus in posterior valve is too often on the lower unit tract. The most profound complication and cause of perinatal mortality in infants affected by severe lower unit tract obstruction remains pulmonary hypoplasia, and that's the commonest cause for mortality. Fetal intervention for obstructive uropathy secondary to posterior valve. Lead to improved pulmonary function in the neonate, be most effective when accomplished by open fetal surgery, be associated with yes, yes. It does decrease the incidence of end-stage disease, and is not definitely the most effective. It is not associated with neonatal respiratory, and so I think it should be C. Yes, fetal intervention for posterior valve has not been shown to lower incidence of PSRD, but in selected cases, it offers the benefit of improved neonatal pulmonary. Yes. Six, all of the following are associated with the development of valve preserves the bladder function rather than causing bladder dysfunction. So I think D should be the answer. Yes. The theory of the valve bladder syndrome. and phenotypic changes that further impairs the contractility of the bladder, and vesicostomy does not impair contractility. So a child with ESRD with history of POV fulguration, all so there is a Nadi creatinine at 1 year of life is important. Renal disease is important. You get valve bladder syndrome, all of the above, right?
इसमें participants दिखा रहा है 4 ये you are also showing कहाँ गया जी
So all these are very important risk factors. Yes. Which of the following is the most common associated anomaly with PUV? PUR, PUGO, renal genesis, hydronephrosis. Most common, PUR. Huh? Renal agenesis is the most common associated anomaly with posterior valve, occurring in 30 to 40% of cases. I'm not very sure. Seems to be a little debatable, I think. A 13-year-old boy with a history of posterior valve with ESRD and is a candidate for renal transplant of the complications listed below, which may be most likely to occur. Acute graft resection, BUR, chronic graft resection, urethral obstruction at the site of uterine neocystostomy, all of the above. So the commonest complication with the surgical complication, that is urethral obstruction, uterine neocystostomy, because these children are very young infants and they may so multivariate analysis compared to a non-posterior valve transplant cohort, but recent studies shown no risk of increased graft loss or patient death despite urethral obstruction, stenting, or dilatation. So here we are, which of the following urodynamic finding is characteristic of posterior valve? Decreased bladder capacity, detrusor overactivity, low pressure void, urethral pressure. Low pressure void? Which of the urodynamic is characteristic? No, I don't think so. C is low pressure void. Initially, it has to be a high pressure voiding. Yes. Still, I am very doubtful of this. Low pressure voiding is characteristic of posterior valve urodynamic, as the obstruction caused by valves results in decreased urethral resistance during voiding. Results in decreased urethral resistance. Okay, I'm not very sure about this. So, So, Dr. Bhatt, what is is it
can you hear me?
decreased voiding pressure? Pardon?
I think this decreased is the right one because there is a dilatation of the post urethral pressure, dilatation of urethra. So when suddenly we come in UPP, the urethral pressure decreases because of dilatation. Because the pressure rises only during micturition. Otherwise, the passage is patent.
Okay. Okay. So yes, so the explanation might be correct then, right? So thank you once again. Thanks all our experts, Dr. Bhatt, Dr. Anil, and here we have Dr. Commissioner also along with us. Dr. Commissioner, would you like to make any comment? Thank you for joining us.
Professor Shivam, I would like to request
Yes.
all the members and the residents to join global webinar today from 5 to 9 p.m. on pediatric urology.
Surely. Surely. So you have put it in the group, right?
Yeah.
Just send me the link and I will circulate this in the group, right?
Yeah, I'll send the link.
Thank you.
Okay. Thank you.
Right.
It was a
Thank
nice
you.
presentation.
Thank you once again. Thank you, Dr. Bhatt, Dr. Kamishra, Dr. Anil Jain, and all the faculty and the residents who might have joined us today. And thanks, everybody. Have a good day.